So good afternoon, everyone. And it's really a great pleasure to welcome you all to our instruction course on managing medical emergencies in eye centers and how to save life and practice. So we have this instruction course designed specifically for eye care centers who are small centers caring for only ophthalmology, subspecialty and super specialty, dealing with large number of elderly patients and vulnerable age group and with high risk status. So we all know many of our eye centers are under-equipped and not prepared to handle them. So this course is specifically designed to focus on some important aspect of managing medical emergencies in eye centers. So we have the esteemed faculty with us, myself, Dr. Nirmal Fredrick, Chief Instructor for this course, and also have Dr. Niranjan Karthik, who will be talking to us about how to assess a patient plan for daycare surgery. Then we have Dr. S. Jayandan, who will be talking about equipment and training required, and NABH standards, which prescribe few standards and standard operating procedure to tackle the medical emergencies that will be dealt by my friend Dr. Senthil, and also have some case studies and videos, and also in case the hospital experiences some crisis because of that, how to tackle that. So this is the overall construction of the instruction course. I'm happy to have you all here. I think people are searching for the hall, and so whoever has joined us, thank you all for joining us today, and we'll start the session right now. Yeah, thank you. So this is my disclaimer, no financial interest. And as I said earlier, medical emergencies are rare medical events, so that may occur unexpectedly. And if encountered, these events require immediate diagnosis and management. And most of us are not ready for the surprises. And as a medical professional, we also need to be aware of the risk and be prepared for the surprises. So many of us are small eye centers, and so this is my assessment of over 150 eye hospitals. We feel that the centers are not well prepared for the risk, particularly the medical risk. So if there are crash cart, they are non-functioning, they might have few expired medicines, and no MOU with ambulance, so there is no transfer mechanism for the patients. And the team is not prepared, so either a single doctor or two doctors team. And the moment there is a medical emergency, they panic, and that too happens all in front of the patient and their family. And non-availability of physician or anesthetic during the procedures, complexity. So basically the resource crunch, particularly the men, material, equipment, and lack of training makes things worse. So how do we go about? So being prepared for medical emergencies is not just about saving lives, it's also about giving hope to those who need it the most, because we deal with life and sight. So during emergency, every second counts. So every life matters, and every effort to be taken to make a difference. So the first step is do not panic. So we all have forgotten general medical care once we come to a specialty practice. So as a doctor, we are all already equipped with dealing with emergencies. So medical emergencies, first thing is don't panic. So we'll go through a few topics in this instruction course. So basically what emergencies can happen in eye centers and how to prepare, how to sense and save a sinking patient in eye care centers. So we'll deal with few cases. So this is the first case, a 35-year-old lady come for incision and curettage for chalazion. And generally we do give xylocaine test dose for these procedures. And after the injection, she complained of itching and suffocating sensation. So on assessment, so patient was awake, oriented, the breathing has become fast, and there was hoarseness of voice, and these were the vitals: tachycardia, tachypnea, and 85% oxygen saturation, and the BP was going down. So these are the hints to diagnosis: sudden onset, secondary to a trigger, that is injection, particularly xylocaine test dose, which is known to cause anaphylaxis. And patient presented with hoarseness of voice and was really acute with a sense of impending doom. So why is it anaphylaxis? Because anaphylaxis happens after this trigger factor. So you need to be aware of this. This is acute, potentially fatal, and this is the classic form. If there is prior sensitization, it follows after an acute event. So there is no need for investigation. You have to act straight away. Anaphylaxis is a clinical diagnosis, and investigations are not going to be helpful in this acute setting. So how do we recognize? So we probably, if you have already experienced in your medical college days or in other centers, you can easily recognize it. And sudden onset of signs and symptoms, and within minutes it happens. It might happen after a few hours also, and it affects the entire body, and a lot of symptoms happen, not easy to recognize. So there is a dilemma whether to give local anesthesia, test dose or not, whether it's mandatory or not. There is no standard guidelines, but if you are exposing the patient to a large dose of injection, better to have a test dose done, and also ask for allergy to preservative. So because there is a cross reaction among the local anesthetics. So you have to do a risk assessment, whether you are going to use lignocaine or sensorcaine. So initial steps in the management basically protect the airway. This is a key intervention, and adrenaline injection along with a cocktail of hydrocortisone and injection avil. And also support with oxygen, cardiac monitoring, and you need to have the IV access and position the patient comfortably in the same place with legs elevated. So this is another patient who came to the hospital for counseling and reception. Appointment with the doctor is scheduled. She was dilated for cataract assessment, and after 10 minutes she became restless. So he went to the reception. She's made to wait politely by the receptionist. So suddenly presented with classical symptoms of cardiac arrest: chest discomfort, sweating, upper body discomfort, nausea, shortness of breath, and giddiness. So this is a classical sign of a myocardial infarction. It is a medical emergency. Code blue was called. So our staff recollected their training and activated the code blue. And so patient was positioned, and we stabilized the patient and transferred to the nearby hospital and cardiac ambulance within 5 to 10 minutes. So third story about a 50-year-old gentleman waiting in the OPD, a well-controlled diabetes because of a regular patient, so we know the history, with cardiac dysfunction, and suddenly become agitated and starts sweating profusely with tremors. So what do you do? And falls to the ground with hands on his head and sweating. So since we know that patient is a diabetic, we did a CPG, capillary blood glucose, and took a ECG as well, and stabilized the patient with monitoring the vitals, and stabilized the patient with the blood sugar. The blood sugar was 62 milligrams, and so oral dextrose, IV dextrose, and glucose in all forms was given. Patient monitored in the ward, recovered, and then sent to the physician for opinion and follow-up. The fourth story, during the surgery, 89-year-old male posted for cataract surgery. It was a dense cataract nuclear sclerosis. Patient was very anxious. The BP has gone up to 110. All types of local anesthesia given. Still, patient was in pain and became agitated. So what to do? We have a anesthesiologist always with us during the surgery. He was checking the monitor, and at some point he had to intervene. He gave IV midazolam. Patient settled immediately. The BP came down within 5 to 10 minutes, and under monitored anesthesia care, we proceeded with the surgery, and the post-op period was uneventful. Patient was discharged as a daycare patient. So debriefing, you all know medical emergencies such like this can happen anytime, any day, in any center. And these are some of the common emergencies, daycare centers: hyperglycemia, anaphylaxis, particularly after FFA to the drug. And the asthma can exacerbate it because of the anxiety in the pre-op state area. Seizures can happen, impaired shock or consciousness, then cardiac arrest. So there are many ways of being sick and defining critical illness. Our staff have to be prepared for it. And so apart from having intelligent people, we also need to have intelligent reception with the facilities for triage and enquiry. It's important that we teach our staff to check the pulse and vitals. And if we are the only doctor, ideal to have a CCTV to monitor the reception area. And we have to train our staff, because most of our staffs are either trained in optometry or in as paramedical people or as vision technicians. So we need to train them about identifying the vital signs, and also the respiratory rate, and also ensure that we notice the saturation rates. And we also need to know our patient, particularly old patients with a lot of comorbidities. We need to make it a point to note in the case record their age and medications. And we need to have some gut feeling if there is a problem in the reception or waiting area. This risk assessment is very, very important. If you don't have an anesthetist, we can still follow their guidelines on patient classification, AIOC2024. So if you are going to take the patient on a local anesthesia or topical or infiltration anesthesia, safe to take patients under AIOC1 and 2, and all others we need to have support from the physician and the anesthetist. So always keep an eye on the high-risk patient group, elderly patients, patient with comorbidities, wheelchair-bound patients, and referred from other clinic with like patients with CKD. So risk to practice. So there is always a risk to practice, the surgeon, as well as a financial risk because of not adhering to these standard procedures. And it's always better to have more number of certified BLS staff, train them and keep them with us. So some point of time they will help us. And so this is very, very important, noting the history and see if there are any red flags during examination. Assessment, not only ophthalmic assessment, general assessment is mandatory, and intervention at the right time, at the right place, whether to treat the patient there itself or transfer the patients. And we also need to communicate with our team if there is any learning. So how are our patients now? The first patient, doing well, was admitted in the ICU for observation for 6 hours, monitored, and was sent home. Our team did a job of documenting them well. The second patient, who suffered a cardiac event, recovered in ICU, was treated medically. Cataract surgery was done after 6 months. The patient is happy because we literally saved their life and gave a wonderful feedback. And our team was very happy that they were able to save not only the life of the patient, but also gave back good vision. So nothing can replace identification and risk assessment at the right time. So skills and knowledge how to be used to restore sight and hope in our patients. So thank you so much. The important benefit of having a trained team with basic life support is the ability to save eyes as well as lives. So thank you so much. We can take questions if there are any questions. I invite the next speaker. So now I invite Dr. Niranjan Karthik, who's practicing with us, to talk to us about how to assess a patient plan for daycare eye surgeries. This is very, very important because mostly we focus on ophthalmic assessment, but it's also important that we focus on general well-being of the patient and do a proper general examination and document it. So over to you, Dr. Niranjan.
Thank you, sir. So at the outset, I would like to thank Nirmal sir for giving me this very valuable opportunity, and AIOC for allowing us to present this instruction course. So after the broad overview from sir regarding how to save a sinking patient, now let's move on to a very focused area of how do we go about assessing a patient who's been planned for daycare surgery and cataract surgery in particular. So nowadays we all know that everybody prefers daycare surgery, and though it comes with its perks, it's very important to not miss out on the important drawbacks that it has as well. So overall agenda is to describe and define what a daycare surgery in opthal practice is. How do we prioritize the different sets of patients? Who is fit for daycare surgery? That is going to be the heart piece of our talk today. And pre-operative evaluation, and what are the goals we try to achieve by doing this proper assessment. So we'll start with the definition, which very much has the essence of it. So the daycare surgery or ambulatory surgery refers to the practice of admitting the patient on the day of surgery after being carefully selected and prepared for a planned non-emergency surgical procedure. Now this is very important. The reason I've highlighted it is the careful selection and planning that goes with it. So what are the benefits of doing this daycare surgery? So you avoid hospital-acquired infections due to prolonged stay, more personalized care, and recovery in a familiar and a home-based environment, low complication rates, and higher patient satisfaction because they usually do not like to stay in the hospital. Now what are the benefits for the hospital? Lesser cost and lesser requirement and demands on the nursing staff. So they don't have to maintain longer records and take care of the patients for a longer duration. And in fact, this doesn't bring in the equation of this bed availability and so on. So more number of patients can be treated and served. And overall, as the healthcare system goes, it reduces the burden of the costs for the healthcare system in general, and it is now being preferred by even the government and the insurance companies to have daycare surgeries because that entails lower costs. But what are the drawbacks or the pitfalls? Now, there is a discontinuity or an interruption in the care because the patient goes back home and they can have some sorts of episodes of pain and whatnot. That can be a drawback. Second is chances of missing on detecting early post-op complications, and last but not the least, poor compliance to drugs. Now, having known the advantages and disadvantages of daycare surgery, who are the patients who should be prioritized for this particular daycare surgery? So, infants and children, they are broadly referred to as a vulnerable patients. So, that includes infants and children, patients above 65 years, those in pain, pregnancy, psychiatric disorders. So, these are the three P's that you need to remember: pain, pregnancy, and psychiatric disorders. Multiple chronic comorbidities, trauma, and lastly, blindness. Blindness referring to non-correctable blindness, which can lead to risk of falls, etc. So these are the patients who you need to be very concerned as far as prioritizing for daycare surgery is. Right. So how do we know who is fit and who isn't? So to start off, like sir had mentioned, the baseline or the foundation is with the fitness with ASA, that is American Society of Anesthesiologists classification. So remember that class 1 and 2 are quite compatible with daycare surgery, but as we go higher in the grades, we need more assistance from the physicians and the anesthesiologist. Physiological status and the fitness should be more personalized rather than considering an arbitrary number of age. So that is very important because people who are 70 can also cooperate for a daycare surgery if they are physically and emotionally fit. Then comes body mass index, which we'll be looking at as an important parameter. And one important thing is, it's not about whether the patient is diabetic or hypertensive, but the stability of the condition that he suffers from. So if he is a patient who's been maintaining his glycemic levels quite well, he can very well be a good candidate for the daycare procedure. So, to condense the big table that we just saw about ASA, this is a simplified version. ASA 1, normal healthy patient, or 2, that with mild systemic disease qualify for a good, comfortable daycare surgery. Whereas 3 and 4 with severe systemic disease and that with a constant threat to life, they need a very good support from a physician or an anesthetist. So now is the BMI. See, we need to remember and should not forget the fact that most of the cataract procedures or any procedures for ophthalm is done in a supine position. So it is very important for the patient's body to cooperate with us for that period of time, right? So one of the parameters which is important is the BMI, body mass index. So more than 50, they are at a very high risk of having issues while during the procedure, whereas less than 40, they are pretty much okay with cooperating for the procedure. Now this 40 to 50 is a gray zone where we need to consult with a good physician and take their confidence in order to proceed with the surgery. Now we'll move on to the exact checklist of what all we need to look at. First, history, general and systemic examination, followed by ophthalmic examination, lab tests, and finally the expert input and the consent. So what are all the key factors which we should not miss? I think that's an easy way to go about it, is to not miss out on the existing comorbidities not commonly found in clinical practice, like thyroid disorders, history of seizures. We tend to miss out on such simple things which can make things very bad for us during the procedure. BPH, like we know about floppy iris syndrome, right? So these are some important histories which can lead to a very complicated or a prolonged procedure time that can again worsen the outcome, right? And not to forget the cervical pain and obstructive sleep apnea. Now, these are two important things because the patient needs to cooperate with us during the procedure, and cervical spondylosis is one condition which makes it restless for them, right? And obstructive sleep apnea can be disastrous because that can have a lot of implications if the patient is in supine position for quite some time. Coming to the medications part, we should not forget that eye is a part of the body and we should treat the body as a whole during the procedure rather than just focusing on the eye. So people who are on blood thinners like aspirin, clopidogrel, they have to be stopped for at least 7 to 10 days prior to the procedure, and ticagrelor, which is a more recent congener, that can be stopped only for 2 to 4 days. Very important part is the low molecular weight heparin bridging for patients who are on acetrom. Those patients who are on acetrom for IHD and so on, they need to be properly moderated and titrated with the bridging before we proceed with cataract surgery to avoid any complications like hyphema or expulsive hemorrhages. Now, general examination, we all know pallor icterus cyanosis. Though we know it, how often do we do it is a big question to be asked. And two important factors which I would like to highlight is the ambulatory status. Remember, we're talking about a daycare surgery, so we need the patient to be restored back to their original state of life at the earliest. So that is one important factor. And hydration status is important in order for the patient to have a good recovery post-op. Lab investigations, the usual investigations like HBBs, TCDC and blood sugar. What we need to focus on is the coagulation profile. Like many patients feel aspirin, clopidogrel is a part of their diet rather than medications and don't tell us the history. So these are some factors which we have used to pick it up in patients who haven't disclosed a good full history of their medications. And to prevent last minute chaos, we have to take the help of an anesthetist or a physician and make sure that the checklist that is required for managing emergencies like oxygen cylinders, nitrogen cylinders, and all of them are proper functioning use. So that is very important to ensure it before the start of the OT session so that we can be in a position to manage chaos. And surgical safety checklist, again to avoid any unnecessary complications post-op like endophthalmitis, make sure that all of it is in place before we proceed with the procedure. So these are things we need to do on our side and not just the patient side in order to ensure a good procedure. And last but not the least, though the patient might have been perfectly fit before the days of surgery, on the day of surgery, it's very important to alleviate the anxiety and stress that goes with the pre-op day on the day of procedure. So it's important for the physician to spend some time to alleviate it before we go ahead with the surgery, because that itself can shoot up the BP and cause whatnot as a complication. To summarize, a very good rapport with the patient and the attendant is important, and very important to explain the importance of the general physical evaluation, because they feel it's okay to live with diabetes and hypertension, but only do we know what it can do to us, do to them during the procedure and to us as well. Optimizing the physical condition before the surgery is crucial, and fitness from a concerned specialist, like I mentioned, is very important. And very crucial is to explain the risk and the benefit of the surgery in concordance with their general condition, and obtaining proper consent which is appropriate for that particular patient. Now that's very important because certain patients fall into high risk not only ocularly but also general condition wise. So it's important to be a king in ophthalmology rather than to be jack in anesthesiology or general medicine. So take their support and go ahead with treating them. Thank you.
Thank you, Niranjan, for focusing on the finer aspect of assessing a patient. And any questions from the audience? Right. May I invite Dr. Jayantan, who will be talking to us about, so we've assessed the patient, now it is, we need some equipment in case there is a risk. So what are the equipment and what are the training required for managing these emergencies, and how exactly we can do the code blue drill? So I request Dr. S. Jayantan to talk to us about the same.
Thank you, sir. So a code blue means that someone is experiencing a life-threatening medical emergency in your hospital. Could be a patient, visitor, or your own staff. Usually this means an cardiac arrest or a respiratory arrest, especially when the patient has got the symptoms of non-responsiveness, no breathing, no neck pulse. It's called a code blue. Right. How to go about? First, you need to create an infrastructure for provision of emergency care to your patient, staff, and of course anyone who walks into your clinic. This includes the equipment and the trained manpower. Then gather information about the latest guidelines about the CPR. It keeps updating. Just gather the information. Document the code blue protocol in your clinic with everyone's role being detailed. And finally, practice it on a routine basis. So you need to know the key BLS components. It starts with the recognition, the compression, airway, and the defibrillation. So once you know the basic, it is easy to actually equip yourself with the equipment that is required for the code blue drill. The one thing that comes in handy when you need on a code blue drill is this crash cart. It's a multi-drawer wheel cabinet with essential medication and tools that are required in the emergency situation. It's also named the emergency cart, emergency response cart, code cart, and emergency trolley. These cash carts will vary from hospital to hospital depending on the individual facility requirement that is available in the hospital and the patient population that it is catering. A hospital that is catering only to the pediatric has to have a different cash card from that of an hospital which encounters to every age group. So the purpose is to provide an immediate access to supplies and medication, facilitate a coordination of emergency equipment to that particular situation, and saves valuable time at the time of emergency. So it has both the external and internal component. External includes the oxygen supply defibrillator. We'll see that in close. The most important of all this is the crash cart checklist and the drug info sheet. So literally and figuratively, the bigger things are often the equipment you may utilize first, and you want to be able to keep them handy, so they are all kept outside. The first one is a portable defibrillator. There are two types of defibrillator. One is automated, the other one is a manual. In an automated, all you need to do is activate, apply the pads. The pads will analyze the heart rhythm and will prompt say whether you need to give the shock or not. Manual defibrillator, the problem is you need to have a knowledge of what the patient is undergoing, whether to give or not, and then proceed. So it's always better to go with an AEDs. Next is a suction apparatus. So it basically clears the airway and it facilitates the intubation. It prevents the pulmonary aspiration. The other one is the oxygen tank. These are the things which is kept outside. So when it comes to the oxygen tanks, the most important thing is to know where the key is, because most of the time you'll have everything but lose a key, and that's when you'll be searching to crank open it and you'll be finding it difficult. So every component has to be labeled and make sure everything is present on a regular basis. So coming to the CPR, the most important is a mask that has been used in a CPR. A pocket mask or a CPR mask is a must. So it delivers a rescue breath during the cardiac arrest or the respiratory arrest. And the next version of it would be the bag valve mask resuscitator. And this helps in giving a positive pressure ventilation to the patient when the patient has got a breathing difficulty. And of course, the oxygen delivery devices that connects to the oxygen cylinder, the oxygen nasal cannula, the simple oxygen mask, or the venturi mask. Depending on the amount of oxygen that has to be delivered to the patient at that particular position, you need to equip yourself with these masks. So next is the drawers, and there are certain general guidelines how it has to be kept. The first one could be the medication, which you're going to use the next most commonly after the instrument that we have it in the external one. The IV solutions, the adult intubations would be the third one. The IV draw blood supplies would be going to the drawer 5, and the IV supplies and tubings. Finally, all the other miscellaneous, whatever you want to keep, you can keep it at the end. So by this way, it is easy for you to access the most important things. So as I mentioned, you need to have a pediatric resuscitation kit in all the places. The best is to create your own crash cart. See how you are equipped, make your own protocols, equip yourself, and then finally have a sheet which gives an idea of how to move about in your cash cart. Knowing where your supplies are located on a cash cart is as important as having it itself. So navigating your way through a hectic code is much easier when you have an organized system of your crash cart. The most important other one is the maintaining an inventory of your supplies. So remember, when you are in an emergency, you don't want to say sorry when you don't have an appropriate endotracheal tube, or to see that your epinephrine is actually already expired. The adult crash box is a miniature version. This can be kept handy in all the smaller places of your hospital, and it will be easy to carry also. This is basically the miniature version of the crash cart. So this is all about the equipment that you need to actually hold in your hospital when you want to handle a code blue situation. So next part is the training. Why is the BLS training important? Because it increases your confidence whenever an old patient walks in. Even if they happen to have emergency situation, it will be easy for you to handle. You are ready to respond to the emergencies, speeds the recovery of the patient and the survival of the patient. So all these happen only if you have an effective code blue team. So basically, effective code blue team is the one which responds immediately to the situation, gives a high quality CPR and a cardiac compression, have a good code team leader, which all these translates as the improved patient outcome. So how is an effective code blue team developed? It's basically through the training program. The BLS ACLS certification is must for all the members of a code blue team. Initial and annual individual team rolling has to be defined and keep modified. And the leadership training for the code blue team leader is very, very important. So BLS, ACLS, there are actually a lot of ways in doing it. First decide, are you going to learn and teach yourself, your team, or are you going to seek the external agency's help in training? So there are a number of hospitals which is giving this training. So there are two ways. One is having a blended learning, other one is a classroom training. Blended is where you actually read all the theory online and then go for the main session, or you can have a complete classroom sessions also. So you will be given a certificate at the end as a BLS or ACLS according to the amount of training that you get. Basically in ALS you get extra this thing about the ECG monitoring, the cardiac arrest symptoms and the pre-arrest emergencies will be handled. So most of your staffs, all your staffs need to get a BLS training, and the leader should have an ACLS training. If you have an anesthetist in your hospital, that's more than enough, and if they are already trained in an ACLS. So once you finish the training, make sure you have a laminated copies of the necessary algorithm both for the BLS and ACLS. So is this enough? If a CPR is performed infrequently, the knowledge and skills are lost within weeks of training. An in-situ training program every 3 months actually reduces the mean time of to start a chest compression. If you're not having a good training, it'll take 33 seconds. And if you have a regular scheduled sessions, it'll come down to 13 seconds. And the defibrillation timing will come down from 156 seconds to 100 seconds. This is what the study says. So the answer to this is have a regular scheduled mock codes in your hospital. So this actually increases and encourages your staff to do whenever there is an emergency. The first thing is to get a BLS mannequin and have a protocol how you are going to have this code. This is announced as a real code. It can be done 4 times a month. If you have day shift and night shift in your hospital, make sure you do it in both the shifts. And it is being evaluated using a standard form, and it has been reframed by using a simulations. We have certain evaluation metrics both in terms of performance, the clinical performance, equipment availability, and the soft skill of the team. So all these evaluation metrics will actually give a good feedback to the team at the end of the mock drill. Mistakes are okay in a mock drill as long as it helps the staff to do better in the real life situation. Participating in a mock drill on a regular basis is only proven way to boost the performance of your staff. So to conclude, acquire the knowledge, develop an attitude to act on time, practice until this skill becomes automatic for you, retain your skills by doing your mock drills, develop and retain good relationship with your police, fire service, ambulance, referral hospital, anesthetist, especially with your own staffs. Thank you.
Thank you, Dr. Jayanthan. The last slide was wonderfully done. And where do we get this equipment? Because very often In our ophthalmic vendors don't deal with them. You can use this mic.
Regarding the medications, generally, it's always better to have a tie-up with some multi-speciality hospitals. And if your anesthetist is actually, you have a regular anesthetist, they can make the list that is being required for the emergencies, and it will be easy for you to procure through your anesthetist. So it's been regularly done in all the ICUs. So all we need to do is, when you finish your BLS and ACLS, it is better you just have a tie-up with an anesthetist, get the schedules done. It is always better they equip, because most of the time they will be the leader who actually handles this. So if they are comfortable with a particular medication list, get the list and then equip yourself.
Thank you. So now, yeah.
Yes, sir. Yes, sir. So as a part of our routine practice, we do give Anxit tablet for 2 days prior to the date of surgery. So this is to not only calm the patient during the surgery, but also for a pre-op workup, pre-op medication. It is better to do that to maintain not only his blood pressure levels, but also his emotional stress part, because what we've observed in our patients is that from the day we've decided the date of surgery, they are always in a tense situation. So it has often helped us to start them on this anxiolytics at maybe a couple of days prior to the date of surgeries. Yes.
Mouth-to-mouth breathing.
So provided if you don't have an ambu bag, yes, definitely is indicated, sir.
No, mouth to mouth in an emergency situation, okay, sir. But when you are in a center where you have all the other support systems in place, better to have ambu bag for efficient respiration. Mouth to bag, in case the ambu bag is not working or it's not available, then we can resort to that.
Actually, to find out the ambu bag and to put it in the patient's mouth, it might take some time. But mouth-to-mouth can be started immediately.
No, that is the reason why we say need to have all the equipments in place. So a crash cart with all these equipment in place really helps. We start monitoring and do this simultaneously. And if there is a team in place, we can all do the entire BLS within a few minutes.
So there's one more mask which I have shown, sir. It's a one-way mask. So it's a mask with a blower. So it actually allows the air to go through, and it will not allow the air rebound back. It's a very handy mask. You can keep it in your small crash box, and you can place it in the corner of your OPD itself, sir.
Sometimes you cover the mask with the mask, the patient will be tolerable, and what will you do then? Patient did not want to keep the mask as he's suffocating little.
No, can you repeat the question, sir?
Why do we cover the eyes with the mask?
Yeah.
The patients are telling that we are suffocating, we cannot get the respiration.
Okay, mask.
They are intolerable.
Right. So
and every patient get up from bed also.
Yeah. So what we do in such cases is we put the oxygen thing under the mask. So once we put the oxygen, they are comfortable. Or there are a lot of air compressors now available. So remove the mask in such patients. So put a drape over that and put the air or oxygen under the mask.
Nose and mouth part of the brain can be cut.
Give it to him, sir.
And the part of the drape in front of the nose and the mouth, if that is removed, then the patients get calmed. Yeah.
So we do have certain things. We can suspend the mask under the microscope, the drape itself. So, and then, so all these are few innovations that can help in patient comfort. Right. Can we move on to the next talk? This is on what standards are prescribed and how do we prepare to tackle medical emergencies. So NABH standards have given certain guidelines and operating procedures regarding how a center should be well prepared to undertake medical emergencies. So we have Dr. Senthil Kumar with us. He is not only an ophthalmologist but also an NABH assessor. So over to you, Senthil, to tell us about NABH standards and preparation to tackle medical emergencies.
Thank you, sir. Need to change the slides. Thanks to Professor Nirmal sir and the organizing team for giving this opportunity. So our chief instructor has nicely touched upon case scenarios and insisting on the need for having qualified staff, training of staff, particularly in reception area, and need for BLS training, and having required resources like equipment, machine, etc. And Dr. Jayanthan has nicely given about that CPR and materials required, especially like AED and a crash cart. So now we will see how NABH has given that under various standards and which serves as a guideline to prepare and tackle medical emergencies. So there are, so everyone will be aware of, there are 10 chapters, and out of that, 5 chapters deal on how to handle a medical emergency. First is access, assessment, and continuity of care. The basic intent of this chapter, as well as the intent of this topic, is emergency patients should receive life-stabilizing treatment and then are either admitted if the resources are available or transferred appropriately to a healthcare organization that has the resources to take care of such patients. So, managing emergency cases in an organization is not an option, it is a compulsion, mandatory as per law. So the facilities required are to set up an emergency room, to have adequate facility, and facility to transfer emergency patients. So for that, we need to have documented policies and procedures that are used for registering outpatients, inpatients, and emergency patients also. Most important is, this is applicable for unidentified patients also. So patients are accepted only if the ECO, that's eye care organization, can provide the required service. An exception is, this is not applicable in case of an emergency. Here, life-saving treatment has to be initiated, and before any decision is taken regarding acceptance, the treatment has to be given to the patient. So this has been nicely dealt upon by previous speakers. The facilities required. The process address mechanism for transfer or referral of patients who do not match the organization resources. So for that, we need to have an documented procedure which address the methodology for safe transfer of the patient in a life-threatening situation to another healthcare organization. Okay. So like Sarah said, the reception people has to be trained well. So they need to identify who are all the high-risk patients, who are all the vulnerable patients, what are the emergency patients, and apart from that, what are the medical emergencies which can happen. So access to healthcare services in the organization is prioritized according to the clinical needs of the patient. So the staff has to be aware of this process of registration and scope of the service provided in the organization, emergency handling of patients, triaging, which has been dealt earlier, and referral process. So in triaging, patient who require immediate treatment. The staff has to be aware of the patients who require immediate treatment and the patient who is stable at that moment and not in any immediate danger, and patients who will require medical treatment at some point once critical injuries have been treated, and for those who are already deceased. So with regard to NABH, then we need some documentation of the training records given and triaging in general emergencies, and documentation of the same in HR records and training manuals. So laboratory services are provided as per the scope of the organization, but there are mandatory items like monitoring of blood sugar, CBC, which is not only required for surgical patients but also for emergency patients. So because with regard to emergency, most of the instruments are sparingly used, so we need periodic calibration and maintenance of all equipments. Otherwise, at time of crisis, we may find that equipment may not be working well. So we need to have an interval, and we need to check that at time of doing this code blue thing. So this is applicable for point of care equipments also, like glucometers, BP apparatus, etc. So emergency services, including ambulance, are guided by documented policies, procedures, applicable laws and regulations. So let us see what are the applicable laws and regulations first. So applicable laws and regulations in India for emergency care are based on, as per our constitution, as per legal precedents, Hippocrates Oath and NMC guidelines, along with recent Clinical Establishment Act and medico-legal aspects. So as per our Indian Constitution, Article 21 is a fundamental right that gives right to life and personal liberty. So there are various Supreme Court judgments, and I will highlight some landmark judgments which has insisted on giving emergency care, like Paramanatha Katara versus Union of India, where the judgment says every doctor in government or otherwise has a professional obligation to extend services with due expertise for protecting life. And in case of Paschim Banga versus West Bengal State, judgment has clearly told no emergency patient shall be denied medical care. And in Save Life Foundation and others versus Union of India, the judgment has given guidelines for hospitals and other departments for protection of Good Samaritan in cases where a normal person at the site of accident or something brings the patient to the hospital, and this judgment has given the guidelines. So as per professional conduct and ethics, a doctor owes a duty of care in emergency to do the best and save life of the patient. So no physician shall arbitrarily refuse treatment to a patient, especially in emergency. So as per Clinical Establishment Act 2011, published in the Gazette of India 23 of 2010, the provisions of this Act, Clinical Establishment Act, makes it mandatory for all establishment to provide medical care and treatment that is necessary to stabilize any individual who comes or is brought to the establishment in an emergency medical condition or an accident case, or a woman who comes for deliveries. This may not be applicable for us, but stabilization in case required has to be done, and transfer has to be done through appropriate means. Documented policies and procedures address the care of patients arriving in the emergency, including handling of medico-legal cases. So for that, the hospital needs to have SOP and protocol to provide emergency care, which addresses both adult and pediatric patients. So let's see what constitutes a medico-legal case. A medico-legal case is a case of injury or illness where the attending doctor, after eliciting history and examining the patient, thinks that some investigation by law enforcement agencies is essential to establish and fix responsibility for the case in accordance with the law of land. So we had seen about triaging earlier, and need for ALS and BLS training has been insisted. So staff has to be trained on the procedure for care of emergency patients, including eye emergencies. So requirements for an ambulance is equipment for both adult and pediatric patients, mandatory licenses, and this equipment has to be checked regularly. Emergency medication stock has to be there and has to be checked regularly. Documented procedures guide the care of patients requiring cardiopulmonary resuscitation. We had seen the resources, material, that staff nurses, trained nurses, doctors, anesthetists, physicians, and display of protocols in all critical areas such as emergency OT, so that everyone will be aware of what has to be done in the time of crisis. All doctors, nursing staff, and allied health professionals in OT must at least be trained to provide basic life support. It includes emergency areas also. The availability of emergency medication is stressed upon, and there should be a monitoring mechanism to ensure that the required medications are always stocked and well within the expiry dates. So hospital infection control, this has to be periodically updated because it identifies various high-risk areas and implements procedures to prevent infection, including emergency area. So to conclude, emergency patient should receive life-stabilizing treatment and then are either admitted if resources are available or transferred appropriately to healthcare organization that has the resources to take care of such patients. Managing emergency patients is mandatory. Resources need to be in order, treatment and referral. Material training should be adequate. Mandatory license should be obtained. Protocols to be strictly followed, and regular training, inspection and calibration of equipment as well as mock drill has to be in place. Thank you.
Thank you, Dr. Sendil. And it is now important that we follow the requirements for the Clinical Establishment Act by treating emergency patients. Thank you for highlighting those points. So we'll now move on to the next talk by Dr. Kumaran Murugesan. Dr. Kumaran is a practicing ophthalmologist at Chennai. Over to you, Kumaran, for your talk on case studies and videos on how you manage emergencies in your center.
Okay, good afternoon all. So at the outset, I'd like to thank AIOS and Dr. Nirmal for this wonderful opportunity. So my previous speakers have told you everything of how to go about with emergencies. Dr. Nirmal told you how to identify a sinking patient. Dr. Niranjan told you how to assess a patient. Then Dr. Jayantan told you what are the things you need to have in your center to take care of it. And the rules are also specified. But you need to understand that when all these are present, but will this work in our place? There are a lot of studies which shows that 9 out of 10 times, the first time when you have a medical emergency in your place, everything goes chaos. So here we are, and most of these centers in India, the ophthalmic centers are either a single doctor or a group of doctors, and every doctor has a specific role in that. And when someone is faced with a medical emergency, forget the doctors, your staff are also not trained to handle them. If you leave your patient to your staff to ask him to prepare him for a cataract surgery, they will do it very easily. But when you have the same situation, a patient faints in your OPD, and if you are engaged in a different emergency situation, the staff are also not well equipped to handle this. So this is why we keep on laying the importance of mock drills to our staff. I normally have the practice of sending one staff to a nearby ICU for every day in a month, so that they'll be very familiarized with the real situations. So here I'm going to tell you of what are the difficulties we faced when we had a code blue situation in our center for the first time. So it is also important that you could learn from my experience and also learn from the faults which we did during the first time. So this happened, see, our center is there from 2005. Initially, we didn't have any of the facilities which Dr. Jayanthan and Dr. Nirmal had put in place. We used to analyze the patient. We used to operate without an anesthetist. But later on, we grew. We get scared when our practices grow. So we have everything in place. But will this work for the first time? So this was a patient who presented to us in 2017, a 64-year-old female who had come to a hospital for the second eye surgery. The first eye surgery was done 4 to 5 days back, uneventful. She was very happy. She came to the hospital. The initial assessment was done. She was shifted to the theater. She wanted to use the restroom as in any cardiac situation. She came out of the restroom. She collapsed outside the OT. So I was operating, so I was not able to go and see the patient. The code blue was activated by our staff, and we really did not know what went wrong. So going back to the history, so this was the patient. Could you please run this video? So this patient actually presented to us 2 weeks back. He presented on a busy OPD. She was coming from a different place, around 70 kilometers from Chennai. All the investigations was done. She was on routine hypertensive medication. We did not bother to go into it because her BP, her ECG, and all the blood investigations were quite normal. She underwent an uneventful cataract surgery. All the checklist was done, and she presented to us on the first post-operative day. She was very happy. Everything went on well. So as in any other ophthalmic center, we decided to do the other eye surgery after 4 to 5 days. We didn't reassess the patient. We just went ahead with the previous medical reports which we had done for the first eye surgery. And when the patient presented to us for the second eye surgery, the patient collapsed. So what really happened? The patient was shifted to the OT. The auscultation showed rales and bronchi, so we went in terms of pulmonary edema. BP was 210 over 110. Oxygen saturation started dropping. The anesthetist was in place, and we started treating the patient in terms of pulmonary edema. The ambulance arrived because this is a point where the importance of having a memorandum of understanding with the adjacent multi-specialty hospital is very important, because you might have an outsourced service for an ambulance, but where do you take these patients? If you don't have an MOU, the nearby hospital must just say that the bed is not vacant, so need to run from hospital to hospital. So always have an MOU with the adjacent hospital, and always reserve at least one ICU bed so that they always encourage the patients coming in from your hospital. And always ensure that the theater notes are written very well. Have your anesthetist to jot down every minute details, and always a good practice for the doctor or at least the assisting nurse to accompany the patient in the ambulance, be with them till the patient is admitted in the ICU. Ensure that the nurse stays there till the doctor goes and takes over in the ICU. So the patient was received in the ICU. We had an MOU with the nearby hospital. Artificial ventilation started. The cardiologist was called in, which showed clear evidence of an MI. The patient was doing well. We came out. We encouraged told some soothing words to the attender. But eventually, around 2 to 3 hours later, the patient had an intraventricular rupture, and we lost the patient. So this is what has happened. So we went backward retrospectively to see what we have done wrong. This was an obese patient. Earlier, my professor used to tell me these were the days when the elevators were not there in most of the hospitals. If your patient is able to climb 1 or 2 sets of stairs, then probably her cardiac condition is quite good. Nowadays, people use the elevator. We just had a superficial look into the patient's history. We did not go deep into the medication. This particular lady was living alone. Her son was not living with him. The ECG was normal. The serology, blood investigation was normal, which we got carried away. And the first eye surgery was uneventful. So when the patient really collapsed, we had a difficulty in whether judging whether the patient was an acute MI or a status asthmaticus. Even the anesthetist was doubtful because her previous investigation was normal. So there was panic all around. We were not able to find an IV line in his obese patients. And the first time we were pacing a code blue, and all the sisters were in chaos. The other thing we should keep in mind is that this patient was obese. You need a particular code team, a code blue member team to have adequate strength of at least 6 to shift these patients in the stretcher and onto your ICU beds. It's always a good practice to record whatever has happened. We did have a CCTV camera, but retrospectively only found that that particular day the CCTV camera didn't function. So it's always important to alert your housekeeping staff to ensure that your CCTV works well. The only soliciting feature for us that everything happened right under the nose of the patient attender. He was able to see what was happening, and because we had an MOU with the ambulance, the ambulance arrived. Just imagine if the ambulance has not arrived, and if you had not had an MOU, we could have been running around finding a bed for these particular patients. Ensure that the emergency notes are written very well, and that too in the event of a death. Make sure you go back to your notes, write it in the proper way, and follow the patient up. So the lessons learned here are you need to have a high degree of suspicion. We deal with a lot of geriatric patients, so make sure you spend some time to look into the medications. Always have an intravenous line. Of course, every patient cannot have an intravenous line, but leave it to the judgment of the anesthetist to decide whether a particular IV line is needed for these patients. We always check all the ophthalmic equipment before you start a case, but also teach your staff to have a checklist for all the supporting equipments. Your Bain circuit, your medical gases, everything should be in place. And kindly assign a separate staff for this. Form an emergency team, minimum of 6 persons, and 1 person to be dedicated to record whatever event that happens. Always have an anesthetist with you who is able to monitor the patients while you're able to do your case well, and always prepare your case sheet well in an utmost care in the case of a death. There are also a lot of other medical emergencies which deal with, which Dr. Nirmal has already mentioned to you about. The one common thing is hypoglycemia. All of our staff should be able to treat this particular condition. Seizures, we do not come across people having seizures everywhere, but your staff should be monitored, taught, and mock drill should be conducted for every clinical situation. It is not only important to have a mock drill for code blue or cardiac situation, but you should also have a mock drill for all these kind of medical emergencies. The other most important thing which we come across is the vasovagal attack. This can also be prevented preoperatively, and awareness, a careful history taking. Preoperative evaluation, the head-up tilt test can tell you about signs about vasovagal attacks. Intraoperatively, do your intraocular manipulation very gently and have your support staff. So summary, a code blue team should be there in every hospital, however small or big it may be. Remember to record the events. Check all your emergency medications and instruments are in place. Have an MOU with the hospital. Make sure it works. Have a standby anesthetist, and frequent training for every emergency situation should be in place. So finally, have everything in place and just pray to God that nothing happens. We are a daycare center. We deal with a lot of geriatric patients, so stay safe in your surgical practice. Thank you.
Thank you, sir. That precisely tells what is the importance of having training and regular mock schedules. Thank you for practically demonstrating what could have happened in the situation if the hospital is not being trained for emergency handling. So now, next talk would be by our Chief Instructor, Dr. Nirmal sir. Before the era of all these CEAs, all these things, PPP stands for Preferred Practice Pattern, purely on a clinical basis. Now, after these litigations, everything came in, the PPP stands for a Public, Press and Police. How are we going to handle them when such a situation handles?
Thank you, Dr. Jayanthan. And so this was the era when physician was treated as God, but now not only the alphabets, the roles also have reversed. And the current situation is we are blamed for every disaster, and there is attack on the physicians. We keep hearing seeing such videos and news about attack on the doctors, hospitals, and also the reputation damage by the Google review and few other aspects. So how do we save the practice as well as the doctor from this risk? So we all know that there's a golden hour in myocardial infarction. So within 1 hour, we need to initiate the treatment and management. Similarly, there is a golden hour in road traffic accidents. Patient have to be shifted and given first aid. Same way, there is a golden hour in medical emergencies and treatment and violent attack on hospital or hospital staff. So this is basically a pressure cooker situation. So the doctor is in a state of shock, and there's always a biased reporting by press and the other stakeholders, and pressure from the police to settle the case. And there are political splinter groups pressing for compensation and agitation by the relatives or certain self-interest group. So basically, it's a pressure cooker situation. It can go either way. And the reason for crisis basically is 4: doctor-induced, staff-induced, drug-induced, or patient-inflicted. So doctor-induced, basically, we need to remember this. Never take over and above your capacity. And in emergency care, so that this always happen, denial, delay, and death. And we have to be very cautious in communicating the bad news. Suppose there is an on-table death or there is a medical event, we need to convey the bad news in a proper way, document it, counsel and communicate, and also prepare our hospital and team for managing the crisis. Most often it is staff-induced because one of our staff may go and spill the beans. So not complying with the instruction, giving a wrong site, route and drug, and explaining that or rough handling of patients and their relatives. And some patients might be demanding handouts. So all this are induced by our own staff. This is where training also really helps. Drug-induced, we can't do much, but we have to be prepared for it, whether it is look-alike, sound-alike medications or anaphylaxis. We have to ensure that there is a proper documentation of drug as well as the 5 rights on the drug aspect. Patient, basically some of the patients hide previous treatment, cardiac angioplasty or disease status and poor compliance. We also have to understand that these things happen. And so these 4 P's are very important. How we are dealing with the police, press, politicians, and the public. So basically in crisis management, prevention is very important. Face the crisis as well as prevent the crisis by learning from the crisis. So this is one important aspect of facing the crisis, that professional rivalry. We need to change this rivalry to professional bonhomie and bridge the gap between our patients. So how do we do this? So we have to listen to the patient. This is the 5th P. And we need to ensure that we listen to the patient as well as communicate to them. Explain the treatment to the patient. If there are risks, don't hide it. You have to explain the risk to the patient in the language and in the way he and the attenders understands. And get informed consent. This is very, very important. Properly inform the patient and get an informed consent. Document everything you discuss with the patient. Counseling is very important, not only on the positive aspect, never over give the outcomes. You also need to give if there is going to be a poor outcome, give it in writing and counsel the patients. The fifth point is tell them the chances clearly. It may be percentage or it may be a bad outcome. We have to tell them the chances clearly. And the sixth aspect is we need to monitor with CCTV or with people about what's happening, not only in the theater, but also in the outside areas, particularly receptions. We need to know our limits. As eye care center, our ability to treat general emergencies is limited. So we have to know our limited limits and try to transfer the patient as soon as possible. So if there is a death, so get in touch with a local association and don't declare the death. Declare the death immediately, but ensure you are well prepared to do this. And it's very, very important that you stay in the flock, stay with the AOS, TNOA, or any state bodies, as well as the local IMA group. And the last commandment is basically follow the standard protocols, follow the regulatory requirements from the CEA point of view, and ensure that you learn from the crisis. This is very important. Not only managing the emergency, what you learned from that emergency and what you learned from the crisis is important. So be prepared for the next crisis and emergency. So you need to acquire the knowledge, develop an attitude to act in time, and practice until the skills become automatic, and we need to retain the skills by mock drills. So wish you a crisis-free practice. Thank you all for attending this program and course. If there are any questions, we can take up before the next chief instructor takes his place. No, it's a lunch time. If there are no question, I think we have the next instructor ready here. So thank you for attending our course. Thank you for your time and attention.